The title of this session is The Decision for the Fasting, which is always a challenge. Certainly a challenge not just for the patient, but also for us as well as healthcare professionals. And we always say that we need to find the right experienced specialist to give that particular advice. Now, how do we come to that decision? It's really very important that we have moved from the simple table of 3 categories, where you lump a person with a particular condition into a group without going a bit deep. As you can see, in reality, we look into Ramadan-related factors, diabetes-related factors, as well as factors to the individual herself or himself. And there are plenty of these factors. Every single one of them is really quite important, including one of the things that we don't really discuss very frequently, which is access to care. I think this is really quite important aspect that we sometimes forget, because a person with diabetes who wants to fast and perhaps is a bit high risk without appropriate access to care would be in risk. Now, the geographical and the cultural differences is well representative in this slide that we have done in the survey that we published last year, a survey that took part for 2020 during the COVID time. And for type 1 diabetes, we had over 1,400 persons taking part into that survey. It's the same month, it's the same Ramadan, it's the same. I do not believe that it is the variation in healthcare which makes the difference in the rates of fasting. Certainly, it's a lot of cultural and regional changes and acceptability as well. But certainly, when you make the decision for the fasting, the type of diabetes is really quite important. As you can see here from the survey, as well as from many other previous data, that in type 1 diabetes, already 30% of the people opt not to fast. And this is really crucial because we need to differentiate between type 1 and type 2. But even in type 2 diabetes, 16% do not fast. Whatever we do and data, it is for those who fasted. And we forget this particularly larger group that opted not to fast at all. So it's really quite important that we remember this. This difference between type 1 and type 2 diabetes is well represented with the rates of hypoglycemia, daytime hypoglycemia, being 62% in type 1 versus 15.7% in type 2. Then come the issue of age and duration of diabetes. Are these challenges that we need to consider when a person is taking the decision to fast or not, or when we are assessing that person? In the new risk score, we have put the duration of diabetes being above 10 to score 1, and age above 70, and perhaps with living alone to be 3.5. Now, we don't have something below the 3.5, and certainly many of these issues are open for review in the future. But let's first discuss age. What about the type 1 being too young? Of course, we know from the religious aspects, Ramadan is for those who are considered as adults. But nevertheless, we know that many teenagers or adolescents, even young children, want to fast. When we looked into the survey of those who below the age of 18 versus those who above the age of 18, there was no fundamental differences between both. In fact, obviously, those who are younger probably have no long duration of diabetes or complications as much as those who are a bit older. So the age being too young is not a major issue. And when the colleagues of ISPAD put the guidelines for the children and adolescents, asking the question, should they fast? Their answer was, with a big criteria that need to be fulfilled first to allow them to fast. So the answer is maybe they can, provided we fulfill certain criteria. Now, classically, when we talk about age, we talk about being older. And when you look into the guidelines, the first guidelines that we did with diabetes, with ADA in 2005, we simply said old age with ill health to be high risk. And we did not mention anything about duration of diabetes. Other guidelines have specified an age being above the age of 75. And they said they may opt not to fast. Some guidelines did not mention anything related to age, such as the South Asian Health Foundation in UK, where we did not mention age or duration of diabetes at all. The IDF guidelines, the previous one, did put the group of age into the high risk, but we did not specify what do we mean with old age. We said old age with ill health, and we did not mention duration of diabetes. But the question really, do we have evidence that age is hindrance towards fasting? I'd like to share with you the data from the survey that we did, and this is data that we just finished analyzing last week, and it's in the stage of, it's being presented in the Dar conference for the first time. So clearly, those above the age of 65, 30% of them opt not to fast, in comparison with only 9% for those who are below the age of 40. So there's a clear difference in the decision of fasting. Once they fast, the average number of days they fast is not terribly different. But when you look into what is the issue if they fast, well, breaking the fast because of diabetes-related illness is nearly double, 9.4 here and 17% here. So nearly double the rate of breaking the fast because of diabetes-related illness, which is primarily hypo or hyperglycemia. And even the actual daytime hypo was higher in those who are a bit older. But perhaps one would say it's mild hypos, we shouldn't be worried too much. But here, look into the attendance to emergency department or the hospital admission. And when you add both, you can see 11-fold difference between those who are young, below the age of 40, versus those who are above the age of 65. Now, that is from those, this percent is from those who develop hypos and not from the overall. So it's clearly a serious point that we have to consider when we are stratifying the person with older age. Now, Ramadan and diabetes is not just about hypo. Hyperglycemia is a problem that we frequently see. And as you can see here, the rates of hyperglycemia are 19 in the above 65 versus 12 in those below 40. And the admission to hospital or ER is also 20% higher for hyperglycemia as we get older. So another issue that we haven't considered in the past is the duration of diabetes. And when you look into this regarding to Ramadan, you look first into the intention to fast in relation to the duration of diabetes, as well as the number of fasting days and breaking the fast. And again, exactly the same pattern as age. So this is those who are below 10 years of duration of diabetes. This is those who are 11 to 20 years of diabetes. And here is those above 20 years of diabetes. Now, this is important because in our regions, many people develop diabetes at young age. So perhaps they are there in their 40s or 50s. But having 20 years or more of diabetes will make them, many of them, nearly 30% of them, opt not to fast. Once they fast, the average number of days is not terribly different, but the rate of breaking the fast because of diabetes-related illness is slightly higher. When you look into hypoglycemia, you also see this same pattern of nearly double, 24% here for above 20 years versus 14% for those who are 0 to 10 years of diabetes. So clearly the duration of diabetes has an impact. And that's not just for the simple issues, but the severity as well. When you look here in blue into ER consultation and look into admission and you add them up, you end up with 4-fold difference between the person with long duration of diabetes versus the person with short duration of diabetes. And it clearly shoots up after 11 years of diabetes. The same with hyperglycemia, as you've seen before, the same pattern. The hyperglycemia is higher, 18% versus 12%, and the frequency of number of days is more, because here 54% only in the 20 years plus have diabetes frequent between 1 to 7 days, which means 46% are much more frequent in comparison with 36.5% for the younger ones. The severity is also exactly the same pattern. ER admission, hospital admission, and here you can see the doubling of the rates of both when you add them together. So duration of diabetes, age matters, duration matters, type of diabetes matter, and certainly the type of therapy matter. This is data from a number of studies in type 2 diabetes, and it's clearly that once you have insulin therapy and perhaps sometimes sulfonylureas as well, you can see the increased rate of hypoglycemia, and that's why the selection of the type of insulin or the type of sulfonylurea is really crucial to try to minimize that risk. When you look deeper into the studies, so here we had a study with Freestyle Libre, so we were able to look into all the parameters that a Freestyle Libre or a CGM can tell us, and you can see the big difference between basal and intensive insulin. So once your patient is on intensive treatment, we really need to try our best to modify the treatment. And with the risk calculator being now available even as an application, it helps a systematic approach. There is no need for me to say something and my colleague next door to say something different or in different countries. The parameters are now 14 different questions detailed into every single aspect of diabetes. And I'm delighted that today we will hear some of the studies that look into the application of the risk score into everyday practice. I think this helps us a lot to have a systematic approach. But one mega challenge in Ramadan is the religious belief. We cannot convince our patients without working hand in hand with the religious authorities. And in many cases, this is what is missing. And in many cases, indeed, this is what's the reason for the big variation from a region to region, where in one region there is one direction and in another region there is the opposite direction. It should not be this way, and we should work together with the religious authorities to explain to them what are the risks of a person with diabetes or different types of problems so that they are in harmony with us. So clearly, we have the new risk calculator that has helped a lot. And I think I would love to see the future with the application of this so that we can fine-tune the risk calculator. Thank you all, and I look forward to the questions at the panel discussion.